Now, okay, now voice is audible. So we have seen Garden classification for femoral neck fracture or neck of the femur fracture. That was type 1, 2, 3, 4. And then we have seen fracture fracture, fracture classification for tibial plateau fracture, where we have type 1 to 6. Type 1 to 3 is lateral plateau fracture, and type 4, 5, and 6 is medial. Okay. Now, Holter Harris for pediatric fracture. Okay, this is very important, and exam questions coming from here. Salter Harris, Salter Harris, or only sometimes it is said Harris classification for pediatric fracture. Salter Harris fracture, most common type, type 2. Most common type, type 2. First, we'll see what is Salter Harris classification. Salter, from the name itself, we can remember Salter. S for straight. S for straight. So this is straight fracture, right? Epiphysis and in between epiphysis and metaphysis. This is specifically for the children. Central classification we use for the children. It is not for the adults. Okay, for the children, epiphysis and metaphysis, these bones are growing bones. Okay, they are not grown bone. They are not the adult bone. For the growing bone, there will be epiphysis, metaphysis, and in between epiphysis and metaphysis, there will be epiphyseal cartilage. Okay, mainly, mainly this classification is based on that location of the cartilage in between epiphysis and metaphysis. So, let's see here. This is a growing long bone. Growing long bone. Here we have epiphysis. Then this is the epiphyseal cartilage, and then metaphysis. Again, we have diaphysis. Then we have metaphysis. This is epiphyseal cartilage, and this is epiphysis. Yeah. So if there is straight fracture in between metaphysis and epiphysis, it is called straight or type 1. Sometimes, sometimes if we see the plain X-ray, because of this cartilage or epiphyseal plate, we can see there is a gap between the metaphysis and diaphysis, but there the gap has a optimum distance. I mean, normal acceptable. When it is more than the normal, then we can see yes, there is a fracture. It is, I mean, little tricky, but we can understand. Make it simple. Salter Harris classification, mainly for the children, based on the epiphyseal cartilage in between metaphysis and epiphysis. If it is in between this and it is straight, then it is called straight. Type 1. Type 2 is A. S, then A. A for above. Which above? Above this line. Which line? For this epiphyseal line, cartilage line. Mainly everything they are comparing with this. If it is above this is above. And this is type 2, which is the most common type of Salter Harris fracture. Okay, it is above. It goes to metaphysis. From the epiphyseal cartilage, it goes to metaphysis. Then type 3, it is SAL, L for lower. So definitely it will be in the lower. It will come into the epiphysis. It will come into the epiphysis. And then SALT, T for throw. In between epiphysis and metaphysis both, it is going through. It is going through this. Then E. E for erasure of growth plate. Erasure of growth plate means, I said before, there is a minimum gap between metaphysis and epiphysis. Okay. When this gap increases, this is type 1. And when this gap decreases, this is type 5. Okay. So there is growth plate. Here, this epiphyseal plate or this growth plate is decreased. Means these both bones gain more uh, compress, compression. Compression. Yeah, this is compression of the physis. Then type 6, it is R, SALTER, R for reaction periosteal. Reaction periosteal. Here, this you can see here, this segment is totally avulsed out. Okay, this is reaction type. There will be ligament here. There will be ligament attachment, and whole this part is broken, and it is type 6. Reaction periosteal. So most common type is type 2, and most bad prognosis is type 5, because when there is compression of the physis and there is growth plate destruction or erosion, because from the growth plate only the long bone increases. Okay, growth plate slowly convert into solid bone, and by this way bone actually increases, or any child increase in length. But if there is any injury in the growth plate, then it is very bad prognosis. Corner sign, there will be like a corner, you can see like a cone, like a cone. This is corner sign. Now, Dennis Weber classification for ankle fracture. Very important. Dennis Weber classification for ankle fracture. You can see they classified the fracture from number A, B, and C. A, B, and C. A, it is starting from the down, then slowly it is going up. A, B, C. So starts from below to above. A, infrasyndesmotic. Here, this is which bone? Fibula, and this is tibia. This is talar. This is calcaneal. We will get talocalcaneal joint, talofibular joint, talotalar joint, and this we will get this thing. So here there will be a band of ankle joint. There will be many fibrous structure. Okay, like ligamentous. A lot of ligament will uh, take part to keep the ankle joint stable. Some ligaments are in the lateral side, as like in the knee. In the knee, we have seen medial collateral ligament, lateral collateral ligament, anterior cruciate, posterior cruciate, right? Right. So in the ankle also, we have some medial ligament, lateral ligament. Okay. So they form a like a network or like a mesh. So it is called syndesmosis. Okay. Here, this is kind of syndesmotic or syndesmosis. If the fracture happens below this line, it is called infrasyndesmotic. If type A, if it happens through this line, this is transsyndesmotic type B, and if it is above this, then this is suprasyndesmotic, and more above is the most unstable. So type C is the most unstable type of ankle fracture. As we go type C, this is most unstable. You can read this part. हम्म। हाँ हाँ हाँ। देखिए, अभी दर्द है, हल्का दर्द है। वो प्रिस्क्रिप्शन कहाँ है आपका? उसमें कोई मलहम लिखा था मैंने, वो लगा रही है? हाँ, आज से वो स्टार्ट करें। नहीं, आज पटे नहीं, वो जो मलहम लिखा, वो दिन में 2-3 बार, और यहाँ पर कोई पानी नहीं लगना चाहिए अगले 4-5 दिन। रात जब आप सोएंगे, एक बालिश के ऊपर पाँव ऐसा ऊंचा करके सोइए, ठीक है? और नींबू पी रही है आप हर दिन कितना? कम से कम 3 नींबू आज से, एक दिन में। वो आप जो भी खाना खाते हैं, रोटी चावल जो भी खाते हैं, नो, जो भी खाते हैं उसके साथ खाते रहिए, पर ये सूखा रखना है। कोई पानी नहीं लगना चाहिए, कोई मेल नहीं लगना चाहिए। और वहाँ पर वो मलहम दिन में 2-3 बार लगाइए, ठीक है? 3-4 दिन बाद आप फिर से मुझे दिखाइए। दवाई तो है अभी तक? मेरा ड्यू अभी आपका ड्यूटी शू पहनना पड़ता है, तो ये फिर से कवर करना पड़ेगा। अगर आप सैंडल पहनकर जा सकते हैं, आप जा सकते हैं। आपका किसका ड्यूटी है? वहाँ पर ड्यूटी की, ठीक है, तो आप नहीं, तो आपको ये कवर करना पड़ेगा फिर से वो। सर तो बोले हम इधर लिख देते हैं ड्रेसिंग, ठीक है? आप वो कवर करके देगा, पर ये जितना खुला रख सकते हैं अभी, उतना जल्द सूखेगा। ड्यूटी से जब भी आ जाएगा ये खोल दीजिए, और आज के बाद आप थोड़ा इधर से वो ड्रेसिंग गोज लेकर जाइए, आप खुद ही घर पे ऐसा कर सकते हैं, ठीक है? नहीं, ये 1-2 दिन में सही नहीं होगा, ये टाइम लगेगा, कम से कम 1 हफ्ता लग जाएगा, ठीक है? अभी इधर से वो ड्रेसिंग गॉज, मतलब तो है आपके पास, आप ड्रेसिंग गॉज ले लीजिए फार्मेसी से, वो उधर लगा कर थोड़ा कवर करके रखिए। ड्रेसिंग गॉज और थोड़ा टेप ले लीजिए, ठीक है? फार्मेसी से ले लीजिए। दवाई तो है ना आपके पास? कितने दिन हुआ? दवाई 5 दिन और नहीं चाहिए, पर वो मलहम जरूर लगाना चाहिए। मलहम लगाकर आप वो ड्रेसिंग, वो कागज देखा मुझे। ओके, सो Danish Weber classification for ankle fracture mainly depends on the position from syndesmotic. If it is above the syndesmotic, it is type C. If it is below the syndesmotic, it is type A. And if it is below, it is B. आप ये कराए थे 20 तारीख, आज से 23 तारीख, तो इधर दवाई थे 5 दिन के लिए, ये 5 दिन के, ये 5 दिन के, ये 5 दिन के। कल खत्म हो गया क्या और हो जाएगा? हम्म, हाँ, तो ये मेडिसिन है पहला वाला, ये और भी 3 दिन के लिए ले लीजिए, ये था 3 दिन का, ये और भी 3 दिन के लिए, और बाकी जो है जितना है वो फिनिश कर लीजिए। इसमें ये टिक मार्क, ये 3 दिन के लिए लिखा है ना। फार्मेसी में जाओ, उधर से मतलब, हाँ ये वाला, ये टिक मार्क, हाँ 3 दिन के लिए, बाकी सब सही है। ओके, हाँ जा सकते हैं। हाँ, वो तो मैंने बोला कवर करना पड़ेगा, कवर करके आप सॉक्स पहन लें। Mhm. Okay. Okay. So when there is type A type fracture, this is just about the fibular head part. If there is any fracture at this level, it is normal. It will improve. Okay. And treatment will be just we need to give some support with the cast. But if it is at this level with the plaster, it will not stay because when they will walk, because of the walk, there will be movement, so it will be displayed. For this type of, if it is type C, then we have to open and we have to do the internal fixation with plate and screw. So stable fracture is below knee cast is the treatment. Okay, below knee cast. Okay, cast is something like suppose this is thigh, this is leg, and this is foot. Okay, this is knee joint. If suppose this is fibula, if it is in the lower, which is type A, then we can just put a slab or we can put a plaster here. Just we can put a plaster. You have seen the plaster, POP plaster. They are saying about the plaster. If there is fracture here, we can give below the knee plaster. See? Below knee cast. It is cast. Mainly they are saying about the cast. Below the knee cast. Cast means the plaster. POP. Only the plaster. Only the plaster is sufficient for the treatment. But if it is unstable means type type C. Unstable is type C. For type C, we have suppose this is fibula and this is the tibia. So for this type of fracture, we have to put here plate and screw. Then we have to fix it like this. And common fibular nerve around the proximal fibula, so ankle boot. Okay, we can give ankle boot also. Pelvic fracture classification. Just you remember this horizontal or vertical. This is stable fracture. Horizontal, unstable, vertically stable. Not important. No need actually this thing. Pelvic fracture for part A. No need. Young Burgess classification. No need. Just remember open book fracture. Open book fracture. It is type 3. This type of fracture. Open book fracture means everything is broken here. This symphysis, then with the sacroiliac joint, sacroischial joint, all it is kind of the pelvis open. Um, hip fracture, hip fracture, hip fracture. One of the common orthopedic presentation. Okay, bimodal distribution, neck shaft angle 30 degree plus minus with 7 degree, anteversion 10 plus minus 7 degree. No need to understand anything from this. Femoral head blood supply mainly from medial circumflex femoral artery and lateral circumflex femoral artery from profunda femoris. You remember those things, right? Femoral head get blood supply from this medial and lateral circumflex femoral artery, medial and lateral. Yes, and they come from profunda femoris. Profunda femoris comes from, okay, anastomosis enter, yeah, external iliac when they cross the inguinal ligament. Then they, one profunda femoris and another femoral proper artery. Maybe, maybe. Anastomosis enter joint capsule posterior. Then one profunda femoris and another one. Another capsule proper artery. Maybe. Okay, so we are going through hip fracture. Okay, it can happen in both male and female, in both gender, and this is one of the common orthopedic presentation. Uh, Symptoms as usual: hip, groin pain, deforming forces impacting on stress fracture. Okay, imaging anterior posterior cross stable lateral view. MRI is the gold standard for hip fracture. For hip fracture, MRI is gold standard. And if it is more than 24 hours, then it is the first line, becomes first line nowadays. Okay. Neck of the femur fracture. We can divide it in like intracapsular and extracapsular. Intracapsular fracture and extracapsular. Intracapsular means within the capsule, joint capsule, right? Hip fracture. We are reading uh, neck of the femur fracture. Remember neck of the femur we studied before, garden. Yeah. Now this is another classification based on the capsule, intracapsular and extracapsular. Extracapsular also divided into two: pre-trochanteric, subtrochanteric. There will be trochanter. This is greater trochanter, lesser trochanter. Okay, this is greater trochanter. Here, this is greater trochanter. This is lesser trochanter. So first is intracapsular, then extracapsular. Extracapsular also pre-trochanteric, before the trochanter, like this one. See here, here this fracture before the, here is the trochanter, but fracture is before the trochanter, like this. And subtrochanteric, which is subtrochanteric 5 centimeter distal to the laser. 5 centimeter distal to the laser. It should be here. 5 centimeter here. Subtrochanteric. 5 centimeter subtrochanteric. 5 centimeter. No need to see, just understand. Okay. In this picture, here in this side, I am showing here. Here you can see the picture. This picture. Okay. This is trochanter in this picture. You can see subtrochanteric fracture. This picture, this X-ray, you can see. Actually, I'm not able to decide my. This is subtrochanteric fracture, this corner, and you can see the how can I show? Distal to the lesser trochanter. If it is 5 centimeter distal to the lesser trochanter, then it is subtrochanteric. Okay. Extracapsular first is pre-trochanteric, means before the trochanter. Then subtrochanteric, it is after trochanter but within 5 centimeter. Subtrochanteric 5 centimeter distal to lesser. And the treatment should be before 48 hours. This is very important because there is chance of avascular necrosis. Even mortality. Why mortality? Because of excessive bleeding and morbidity, mortality and non-union. So it is an emergency. Within 48 hours, we have to operate. Subtrochanteric fracture fixed by IM nail, intermedullary nail or PFN, proximal femoral nail. I love this word. I love orthopedics. I, love, I really love orthopedics. Subtrochanteric fracture, uh, subtrochanteric fracture fixed by intramedullary nail, intramedullary nail, or proximal femoral neck nail. This is PFN. This is intermedullary nail. Within the medulla, here. Within the medulla, they are putting the nail. This is called iron nail. And begin with the screw. You don't need to go deep into this. Just you need to remember subtrochanteric fracture. It is treated by proximal femoral nail or intermedullary nail, PFN. And pre-trochanteric. Pre-trochanteric means it is before trochanter. Here is the trochanter. Suppose this is the trochanter. This is trochanter. If it happens before the trochanter, up. Before means up. Then uh, reverse oblique. If it is reverse oblique, fixed by intermedullary nail or PFN. Same. Pre-trochanter. See, subtrochanteric and reverse oblique. Subtrochanteric and reverse oblique. Both are treatment same. Intermedullary nail and PFN. You got it. By intermedullary nail means subtrochanteric. I can, yeah. This is trochanter. You can see this is the trochanter, laser trochanter. So subtrochanteric means within 5 centimeters from here to here, within 5 centimeters. If any, suppose this is 5 centimeters up to here. If it is after 5 centimeters, then it will be called shaft of the femur fracture. This is called the shaft. This is head of the femur, neck, laser trochanter. Now here will be the uh, greater trochanter. Then like this. Okay, this is the femur. This is head of the femur, neck of the femur. This is greater trochanter. This is laser trochanter. Now we are reading fracture neck of the femur, right? First we divided it intracapsular and extracapsular. Intracapsular is only intracapsular within the capsule. This is acetabulum of the hip. If it happens something like here, this is intracapsular within the capsule. Now extracapsular has two. One pre-trochanteric. This is a pre-trochanteric. Pre-trochanteric means before the laser trochanter, maybe here. If fracture happens in here, pre-trochanteric here or here or here. Okay. Subtrochanteric, from here we can come up to 5 centimeters. Up to here, 5 centimeters, 5 centimeters. This is called subtrochanteric. Either pre-trochanteric or subtrochanteric, our treatment option is IM nail. We can put here intramedullary nail, IM nail. Okay, we can put here IM nail and then we can fix. with the screw. Okay, both. This is what I was trying to say. Subtrochanteric fracture, which is within 5 centimeters, can fix by PSN or IM nail, and pre-trochanteric, if it is a reverse oblique, then we can fix it by the same PSN. But in mm, inter inter intertorch fracture, according to the stability of the parts. Stable intertorch. Intertorch means both trochanter. This is greater trochanter, lesser trochanter. Through this, if it happens something like this, depends on the stability. If it is stable, then dynamic hip screw. We fix it by dynamic hip screw. Something like this. Something like this. Dynamic hip screw. And if it is unstable, then intermedullary nail as like before, or DHS. This is dynamic hip screw. Same. Dynamic hip screw means intertrochanteric, both from greater to lesser, both trochanter. If it comes, it is little confusing. There are so many parameters to differentiate this. Keep it simple. If it is intertrochanteric, both trochanter, it is called IT fracture or intertrochanteric. Then depends on the stability. If it is stable, can do with DHS or dynamic hip screw. If it is unstable also, up to a certain degree, can fix with dynamic hip screw. If it is not, then we have to do by intermedullary nail as like before. Intracapsular hip fracture. Now these are those parameters. Intracapsular, before we didn't say anything about intercapsular, just intercapsular, and we explained about the extracapsular fracture. Now intercapsular fracture. Intercapsular fracture, if it is undisplaced, intracapsular, but if it is not undisplaced, then just it is as like fixation in all age groups irrespective of other consideration. Okay, mostly it improves by casting or immobilization. But if it is displaced fracture, then we have to consider two things. If it is displaced, yes, their age. Displaced fracture below 60, and this is above or 60 and above. If it is below 60 and there is no risk factor of osteoporosis and some risk factor, but two types. Displaced fracture, patient is below 60. When below 60, again have to think about two. Patient has any risk factor? Yes. Or patient has any risk factor? No. If patient has any risk factor, but age is less than 40, then we can do reduction and fixation. We can do reduction and fixation by what? Dynamic hip screw. But if patient has no risk factor and age less than 60, then also we can fix by dynamic hip screw. Again. Intracapsular fracture, if it is undisplaced, just we can do immobilization by cast, by hip immobilization. But if it is displaced, we have to consider age. If age less than 60 with no risk factor, then we can fix with dynamic hip screw. But if age less than 60, if specifically less than 40, with some risk factor, maybe patient is smoking or have hypertension or some obesity, diabetes, then we can also fix with dynamic hip screw. Now, age 40 to 60, and he has some risk factor of osteoporosis, maybe family history or some other bone disease like rickets or osteomalacia, anything. Then we have to give him a brand new hip because with the old one he cannot survive. We have to give him a brand new hip. That is by total hip replacement. I like this procedure. This is very nice procedure. Total hip replacement. They totally give a socket and a ball. Socket will be fixed in the hip bone, and ball will be in the femur. So just ball will go inside the socket, and then it will be functioning fully. It's something like magic. So age 40 to 60. Why actually they are doing this? They are considering patient's survival. How long this patient, if anyone is 40 like you, okay, so anyone, he has a whole life ahead. So for him, he needs a total new hip because with the osteoporosis, maybe he will go for 1 year, 2 year. Again, there will be a fracture, and already patient came to you with a fracture condition. And if you can give him next 20 or 40 or 50 years assurance that he can go with this, then this is better than just fixing with whatever he has, but the defective one, which can run for maybe another 2 or 3 years. That's why they do this type of consideration. If age 40 to 60 with risk of osteoporosis, then total hip replacement. Again, age 60 and alcohol using, then have to do bipolar hemiarthroplasty. Bipolar hemiarthroplasty. These all are the type of hip fixation. Here they don't replace the um, hip. A fixed procedure, bipolar hemiarthroplasty. You will go through it. Now, displaced fracture, age 60 and above, depends on patient's quality of life. If patient is active, independently mobile with no cognitive impairment and major medical comorbidities, then he also deserves to have a brand new hip because he's active, mobile, he's running, jogging, he's playing football, enjoying with the grandchild at this age. So he should move more days with a new hip. So he's offered with a total hip replacement because he's active. Though his age is more than 60 but active. Now, independent mobile or no mobile cognitive impairment, no or mild cognitive impairment, mobility limited to house or short distance outside the home, then this patient also will go for bipolar hemiarthroplasty. For example, someone is able to go for shopping or just can go for washroom independently without anyone's help. For this type of patient, okay. So we are discussing about intracapsular fracture, which is displaced, and patient age is more than 60, but he is very active. He can run here and there, can play football. So he is given a new hip, which is called total hip replacement. Okay. And but if someone has limited mobility, like he can go to washroom, can take shower, can go to kitchen, and just can walk short distance, but not for long. He cannot go for shopping in the market, supermarket, or like that. For him, okay, we can replace, but not the whole. Not the whole. We will just give him the head of the femur, just this part. Hip joint, actually, ball and socket type of joint. In the hip joint, this is acetabulum or the socket, we can say socket, and this is ball. In total hip replacement, we change both. We change both femoral head and acetabular cavity. Okay, both we change. But in bipolar hemiarthroplasty, only we change this one. Bipolar hemi hemiarthroplasty. In bipolar hemiarthroplasty, only we change this one. But in the hip, we don't do anything because his hip is not good enough to support to hold this socket. You got it? Almost same. Almost same. And now patient has some cognitive impairment, poor function, major medical comorbidities, maybe some cardiac issues, some heart failure. Then just modern uncemented bipolar hemiarthroplasty. After a long days, I got this term, uncemented hemiarthroplasty. Okay. When they do bipolar cemented hemiarthroplasty. Yeah. When age is more than 60, they put some cement. Cement is kind of like calcium. They are calcium uh, composition. Okay, because patient is already have some risk of osteoporosis. Their calcium level is not good enough. Okay, so when when we do the surgery, we put some calcium beads, or it is kind of powder, just kind of powder, like some people use on the face. That kind of powder. So it will make the joint more stable. But those cement has some mm, chance of allergic reaction or some uh, adverse effect. Though those who already have some comorbidities and some life-threatening issues, for them we don't want to increase their risk by giving more cement. Okay, that's why for them we also replace the hip joint, but we don't give any cement. That's why it is modern uncemented bipolar hemiarthroplasty. This is something risky, and the joint doesn't become that much strong. There is chance of again displacement. But what to do? We cannot give them cement. It is clear. From here you will get minimum two or three questions. Okay. Femoral neck fracture. You can see how you can if a patient come to you on stretcher, or if you see any patient, yes, the leg will be externally. Suppose this is the both foot. So this foot will be something like this. It will be externally rotated and it will be shorter. See the distance? It will be shorter. It will be shorter, externally rotated. So it is shorter and externally rotated. By seeing, and here you will see deformity. Next fracture. Now, posterior hip dislocation. Posterior hip dislocation, adducted. It is internal rotation and it is adducted. It is abducted. Knee will be extended, laterally rotated leg, and in posterior hip dislocation, it is adducted, internally rotated, and flex at the hip and the knee. Here also flexion, here also flexion, with knee resting on the opposite thigh. Knee resting on the opposite thigh. So this is posterior hip dislocation. Now anterior hip dislocation will be opposite. Hip will be adducted and externally rotated. Okay. With anterior hip dislocation and femoral neck fracture, what is the difference? Both are externally rotated, but the position of the knee in femoral, it is extended and this is flexed. Yeah, this is the difference. Good. Okay. Flexion, contracture of the hip. Flexion, contracture of the hip. Flexion, contracture of the flexed hip. Okay. जी, क्या हुआ था हाथ में? বাংলাদেশি না? বাংলায় বলেন কি করে? আপনার কিছুদিন আগে স্কিল এক্সাম জানি না আপনার লাভ ছিল, ঠিক আছে? তাছাড়া পুরো ইয়ে গেছে, এখন কোনো দেখতেছি এটা কাউকে দেখাইছিলেন এর আগে? না, আমি যেখানে ছিলাম আপনার এখানে কতদিন আগে হয়েছে এটা? কিছুদিন আগে, আপনার প্রায় 20-25 দিন আগে খুব লাভ হয়েছে, সত্যি তো পানি খারাপ। নাম কি আপনার? বয়স? চোখে দেখতেছেন না কতদিন থেকে? একেবারে কিছুই দেখতে পান না? ওই চোখ বন্ধ করেন, ওই চোখ বন্ধ করেন। হ্যাঁ, এই চোখ খোলা রাখেন। কিছু বুঝতে পারতেছেন? বলেন তো, লাইট কোন দিক থেকে আসতেছে? চোখে কোনো লাইট বুঝতে পারতেছেন? लाइट এখন কোন দিক থেকে আসতেছে? इनको इतना देर क्यों किया डॉक्टर के पास लेने के लिए? ये तो आँख खराब हो गया। আপনাকে চোখের ডাক্তারের কাছে যেতে হবে। उनको आई स्पेशलिस्ट के पास भेजना है अर्जेंट। अभी अभी भेजना है। अभी तक थोड़ा थोड़ा लाइट परसेप्शन है, थोड़ा उम्मीद है, थोड़ा। ये आँख शायद ठीक हो जाएगा या ये तो बर्बाद हो जाएगा, पता नहीं। पर 1 मिनट भी लेट नहीं करना चाहिए। मैं इधर अर्जेंट लिख दे रहा हूँ, कोई आँख आई स्पेशलिस्ट के पास भेजने के लिए। किधर मिलेगा इसको? इधर एक तुम्बे तुम्बे है, आप ये नंबर ले लीजिए थोड़ा। 971 056 1056। नहीं नहीं, आप काट कर पहले से लेके 056 795 5076। ये है तुम्बे, इधर मोहिलिया में। उधर पूछे आँख का डॉक्टर अभी है या नहीं। अगर है तो तुरंत लेकर जाइए उधर, वरना कोई। हाँ, कॉल कर सकते हैं। पर्दा नहीं है, वो अंदर से प्रॉब्लम हुआ। आपका मशीन से सही तरीके से चेक करना है। इधर मोहिलिया इधर ही है नजदीक। आप चाहे हम्म,
हेलो, अस्सलाम वालेकुम। हमको डॉक्टर आप बुलाए। हाँ हाँ। जी जी। ये लोकेशन आप किसी करो। लोकेशन
আচ্ছা বলবেন একটু ঠিক করে দেখাইতে,
अभी
দেখে সব চিকিৎসা শেষ করে না তো আপনার এই চোখ কিন্তু নষ্ট হয়ে যাবে। ठीक है, तो आप ये लेकर उधर जल्द चला जाए, जहाँ पर भी मिले, एक टुंडे हॉस्पिटल या कोई भी गवर्नमेंट हॉस्पिटल, जहाँ पर भी मिले, ये अर्जेंट बेसिस पे, वरना इससे सारे जिंदगी का आग चला जाएगा। अभी जो हालत में है, शायद ठीक हो जाएगा।
हेलो। जी जी। अच्छा। और
আচ্ছা তুই কি গেছিলি বা ওই সফট কপিকে দিয়ে আইছিস নাকি ওই জায়গায় ওর সাথে কথা বলছিস বা কি কথা হয়েছে আমার একটু একটা ভয়েস দিয়ে বলে জানা।
गाड़ी है। ये गाड़ी तो है हमारी। जी जी। जी।
ठीक है भाई आ जाइए, जहाँ पर भी मिले, अगर उधर मिले तो उधर, या वो खासमिया हॉस्पिटल, रशीदिया हॉस्पिटल, जहाँ पर भी, वो सब भूल जाइए अभी। आईडी कार्ड है या नहीं वो भूल जाइए, क्योंकि आँख अगर खाते में, नो नो नो, वो नहीं पूछेगा, सिर्फ नाम पूछेगा, ये है इमरजेंसी। अगर वो पासपोर्ट है, पासपोर्ट से भी काम चलेगा, पर ये लेट मत करे क्योंकि इसका आँख चला जाएगा। जो भी है आँख ही इसका, आँख के डॉक्टर दिखाना है, ठीक है। কি হয়েছিল? সোজা পা, পা যদি আরাম করে, দুই পা তোলেন, দুই পা তোলেন। হুম, কি হয়েছিল বলেন? হুম হুম। এখান থেকে নিচে থেকে ঢুকে ওইদিকে গেছে নাকি? হুম হুম। আচ্ছা আচ্ছা, আমি দেখতেছি। ওহো, নিচে আসছে এখানে। ঠিক আছে। হুম। Take a local, then we'll change his position. Here we'll take this side. আপনার একটা সেলাই লাগবে ভিতরে, ভিতরে অনেক কেটে গেছে। হুম। খাওয়া দাওয়া সবই করতে পারবেন, সেলাই না দিলে যখনই খাবেন ওই কাটা জায়গার ভিতরে খাবার ঢুকে যাবে, তখন ওখান থেকে ইনফেকশন হবে। নিচে নিচে নিচের দিকে ইয়ে হয়ে গেছে। ঠিক আছে ঠিক আছে। হুম, সেলাই লাগবে। উঠেন, আপনি উঠে মাথায় দিকে দেন। Okay, so this part also done. Actually, I have some trauma case I need to go. Shoulder dislocation. This is also important. Mm, shoulder dislocation. Just remember the image view. It is EP view, axillary lateral and scapular Y view. Remember this X-ray name. AP view, axillary lateral view, and scapular Y view. Anterior shoulder dislocation. This is an emergency. Anterior shoulder dislocation is an emergency, and this is the most common type. Okay. Treatment: prompt pain control and reduction of the dislocation, immobilization. This is the treatment. Anterior shoulder dislocation. Posterior shoulder dislocation. It happens due to seizure. This is the exam question. In seizure, which type of shoulder dislocation happens? Posterior shoulder dislocation. And how you will know? Arm held adducted in internal rotation, like this, like this. Arm held adducted in internal rotation, and inability to actively or passively externally rotate. Okay, palpable posterior fullness, yes, and from pain control, reduction, and dislocation, immobilization. Inferior shoulder dislocation, arm overhead. Actually, inferior, it is something like this, and they cannot make the shoulder normal. You can see the picture and you will understand. And this is rare and risky. Inferior shoulder. AC joint injury. AC is acromioclavicular. Acromioclavicular joint injury. Acromioclavicular ligament injury. It has different type. Type 1, type 2, type 3. No need. This one. Okay. This one is in a skip. Anterior dislocation, most common type, and it is reduced by these are the methods. This is the exam question. Anterior dislocation, most common type. It is an emergency. We have to reduce it urgently. Reduced by Simon's method, Milch method, Hippocratic method, and counter method. Okay, just you read. And what will be the associated injury? There will be anterior glenoid labrum avulsion and blanket lesion. Blanket lesion. When they try to do the reduction, there will be injury. There will be injury of the joint labrum, glenoid labrum injury, and it is called blanket. Not always. I don't use this method. Posterior dislocation. This is exam question. In the X-ray, light bulb appearance, and 50% missed, 50% traumatic loss in internal rotation. Posterior dislocation in the X-ray, there will be light bulb appearance, something like this. Light bulb appearance outside of the joint capsule, and maybe associated with posterior glenoid labrum and reverse blanket lesion. না সেলাই লাগবে সেলাই লাগবে সেলাই লাগবে না পেটে সমস্যা হবে না ওইটা ঠোঁটের সামনের দিকে আমাদের খাবারটা যায় ঠোঁটের পিছনের দিকে অসুবিধা নেই Okay, I have to go now. Inferior dislocation, superior dislocation, just carpal bones, then fracture. We are almost done. Almost done. You can go through the next part by yourself, and once I'm done, then I will try to continue. Okay? Welcome. Okay. কি অসুবিধা কি অসুবিধা হুম Okay, we'll start again. Okay, we'll start again. We are discussing about shoulder dislocation. Inferior dislocation, it comes along with rotator cuff injury or occur rotator cuff tear. What are the muscles in the rotator cuff? Okay, by reading more and more. Inferior dislocation. Mhm. Okay, so in inferior dislocation, there will be rotator cuff tear and glenoid fracture, and superior dislocation occurs with clavicular fracture and acromion fracture. Okay, you need to go back and read. Even if I tell you 10 times, you cannot remember. No, no, unless and until you develop your way to remember, because already this was explained more than 10 times. Okay, now carpal bone. We'll try to finish little rapid. Come to carpal bone. This is carpal bone, 8 bones. There will be total 8 bones in 2 rows. You have to remember every bone name with the serial number. Okay. What are the names? Scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, and hamate. We'll see. We'll get this thing again and again. Remember from here. No tendon attached in scaphoid, lunate, and triquetrum. There will be no tendon, but there will be ligament. So no tendon in this SLT salt. SLT salt. In salt there is no tendon attached. Salt is scaphoid, L lunate, and T triquetrum. Salt in salt there is no tendon. Okay, but there is ligament. And scaphoid bone, it is most carpal bone to be fractured. This is also a question. Which carpal bone most commonly fractured? This is scaphoid. Okay, and watershed area around waist. Most important, blood supply is retrograded distal 80%. In wrist fracture, proximal pole will go for avascular necrosis and non-union. Tubercle gives apart from radial collateral no need. From here, you need to remember if there is scaphoid fracture in scaphoid. Suppose this is radial for radius. This is radial part. This is scaphoid bone. Okay, here you can see. You can see in the picture. Scaphoid, it is attached with the radius, and this is the radial part and this is the distal part. Normally, suppose this is my hand. In my hand, blood supply going from proximal to distal, right? From proximal to distal. But scaphoid is opposite. It's blood supply coming from distal to proximal. Distal to proximal. That's why if there is any fracture and its blood supply coming from in this direction, okay, distal to proximal. So if there is any fracture at this level, which part will be affected? Proximal part or distal part? Scaphoid. Suppose this is scaphoid, okay, this is scaphoid, and this part is attached with the radius, and its blood supply coming from this direction, from distal to proximal. If there, yes, proximal part will undergo avascular necrosis. This is exam question. Treatment of scaphoid fracture. If it is displaced fracture, then operative treatment. Have to do open reduction and internal fixation. Okay. means operative treatment. If it is displaced, if it is non-displaced, then first 6 weeks we cast immobilization. We first give a cast, tapered cast for 6 weeks, and after 6 weeks again we evaluate clinically. There will be little stiffness, then we advise for physiotherapy. Okay, so 6 week cast immobilization, then clinical consolidation and physiotherapy. No clinical consolidation, then X-ray 2 weeks. In X-ray, if we found still it is not united, then we can extend it for another 2 weeks. If no clinical consolidation, X-ray to comparative vision, bone. Just remember, exam question actually come only this much. If it is displaced scaphoid fracture, treatment option is operative. Here you can see, not displaced, then scaphoid cast for 6 weeks. If it is displaced, then internal fixation or operative treatment by percutaneous screw fixation by Herbert screw. Percutaneous screw fixation by Herbert screw. Okay. And diagnosis X-ray, AP and lateral view, scaphoid 30-degree extension and 20-degree ulnar deviation. It is something like this. 30-degree extension. This is flexion and this is extension. So we have to do 30-degree extension and 20-degree ulnar deviation like this. Ulnar. This is radius and this is ulnar. So ulnar deviation 30-degree extension in this position. Then scaphoid we can see properly. Bone scan is best, but MRI if it is within 24 hours and if it is after 24 hours, then CT scan. Subclinical scaphoid. X-ray normal. This is also a diagnosis. X-ray showing no fracture. X-ray showing normal. But patient has clinical pain. How? If we press over the base of the thumb here, here. If we press here, patient will have severe pain. Suppose patient fell down and we have done X-ray. In the X-ray it is showing normal, but clinically when we are pressing, patient is having severe pain. Then this is called subclinical scaphoid. Okay, it's a normal but clinically suspected of fracture. In that case also we apply scaphoid cast. Then lunate, most common carpal bone to be displaced. Lunate is something like moon. Moon is mobile. Sometimes we are watching moon in the right side of the sky. Sometimes it is going left side. So it is mobile. Means it is displacing. So lunate is the most common bone to be dislocated. Okay, lunate dislocation. And avian lunate is called Kienbock's disease. Very rare. Capitate, largest carpal bone. Largest carpal bone, capitate. Fracture, disruption of the bone cortex from trauma associated with other joint injury. Okay, types of fracture. Simple fracture, little, little or no bony displacement. Simple fracture. Compound fracture, rupture the skin and bone protrudes. Compound fracture means it is kind of open fracture when bone communicate when there is skin. I mean when bone communicate with the exterior or bone comes out from the skin. It is called compound fracture. Green stick fracture occurs mostly in the children whose bone have not calcified or hardened. Green stick fracture. Okay. You know why green stick fracture is being called green stick? You know the bamboo or any green stick. If we try to press from one side, there will be little tear of the skin of that, and same green stick tear is something like the same. Transverse fracture according to their fracture location. Cracks perpendicular to the long axis of the bone. Displacement may occur. Oblique fracture also same, just due to their fracture position. Spiral same. It happens due to twisting. It looks like a spiral shape. Comminuted means More than two fragments. Comminuted crushing fracture more commonly in elderly. Okay. More than two fragment is actually comminuted fracture. We have seen patellar fracture, comminuted patellar fracture. Remember? Impacted fracture. One end of the bone is driven up into the another. Impacted is like this, like overlapping, impacted. And depressed we have seen in the tibial plateau fracture. Lateral type 1, type 1 only lateral, then type 2 lateral and depressed, type 3 central depressed. Mm, yeah. So in the bone, skull also we can have depressed fracture and avulsion fracture. Fragment of the bone is pulled away by the tendon. Remember Maurice Salter fracture type 6 we have seen here there is fracture and it is avulsed and it is connected with the tendon. That's why this part is connected with the tendon, but this part is away from the bone. Periosteal connection. This is normal transverse fracture, oblique fracture, spiral fracture, comminuted fracture where more than two fragments, avulsion fracture where it will be connected with the tendon, then impacted fracture, fissure fracture or hairline fracture, and green stick fracture which occurs in children. Force make fracture open versus closed. Okay. This is open fracture when bone fragments come out through the skin, and this is closed fracture. Uh, Gastillo-Anderson open fracture classification. This is exam question. Gastillo-Anderson open fracture classification. ওটা খুলে ফেলতে পারবে এখন। খাওয়া আজকে চেষ্টা করেন এখন একটু ওই ঝাল কম, কারণ ঝাল খেলেই জ্বলবে। উনি জুস টুস খেতে পারে, তরমুজের শরবত, আমের শরবত খেতে পারবে। ওকে। Gastelum-Anderson open fracture classification. It has type 1 to 3. Okay. Type 1 to 3. Type 1, it is open fracture. Okay. Gastelum-Anderson is open fracture classification when disruption is less than 1 centimeter. Then it is called type 1. Okay. If it is type 1, within 24 hours we can do the wound closure. I mean, we can repair. We can do the primary closure within 24 hours. So type 1, 1. Type 1, 1. Less than 1. Type 1, less than 1 centimeter, open up. Type 2, more than 1 centimeter without extensive soft tissue injury. It is more than 1 centimeter, but there is not much soft tissue injury. This is type 2. And here, first we need to take care of the soft tissue. It takes 24 hours. 24 hours after wound closure. 24 hours after wound closure. Type 3 has different grade A, grade B, grade C. This is exam question from here, mainly type C. Grade A, severe soft tissue injury part, adequate bone coverage, highly contaminated. Highly contaminated. Grade grade B, grade C. See, grade 2 and grade 3 difference is both are more than 1 centimeter, but grade 2 it is not contaminated, it is not infected. I mean, it is not sufficient. But grade 3 is highly contaminated, means it is mixed with maybe oil or chemical or any dust or mud or anything. So, severe soft tissue injury and it is highly contaminated. Here we have to give first generation cephalosporin and aminoglycoside antibiotic and 48 to 72 hours after wound closure. We can close the wound after 3 days because first we need to take care of the infection. Grade 1 highly contaminated. Grade highly contaminated, but bone is covered with the muscle. Okay, bone is not exposed. In grade 2, severe soft tissue injury, massive contamination, and bone is exposed, and there is periosteal stripping. Means bone also open. If we see the picture, it will be more clear. Gastric Anderson type 3B, where contamination is there, both in grade A, grade B, grade C, all are highly contaminated. But in grade A, contamination is there, but bone is covered with the muscle and the tissue. Grade B, bone is exposed, and grade 3, blood vessel injury. Same as 2, but with an arterial injury present and requiring repair. And type C, blood vessel also injured. So you have to call vascular surgeon. First, vascular surgeon, he has to repair, then orthopedic surgeon will take over. Monitor, document neurovascular status, tetanus prophylaxis, shoot debrided lavage within 6 hours. No internal fixation, yes. In type C, we will not give any internal fixation because already outside it is contaminated. So if we do any internal fixation, it will be infected. We prefer external fixation according to the condition. Okay, fracture healing. As you have already completed pathology, so you must know. Yes. So, bleeding vessel in the bone and the periosteum. In the bone, what is the blood supply in the bone? What is the main blood supply of the bone? What is the main blood supply of any bone? I mean, what is the main blood supply of the bone? My question is how a bone gets supply, blood supply.
The artery is one too.
Which artery? Nutrient artery. The main blood supply of the bone is nutrient artery. Nutrient artery. Main blood supply of the bone, nutrient artery. Okay, and along with that there will be some periosteal artery and others, but main blood supply of the bone is nutrient artery. Every long bone in the center there will be a hole like this. Suppose this is a long bone, there will be a central hole through which nutrient artery enter, and they give in branch in both sides. So this is nutrient artery for any long bone. Nutrient, nutrient, nutrient. Okay. So any bleeding vessel into the bone and the periosteum, clot and hematoma formation. Then the clot organizes over a week, improve structure and collagen. The periosteum contains osteoblasts which produce new bone. Then connective tissue with hyaline cartilage forms callus. Then trabecular bone formation. Trabecular bone is resolved by osteoclasts and replaced with compact bone. So in summary, hematoma formation, this is the step you have to remember. After any bone fracture, there will be disruption of the bone and soft tissue. So there is hematoma from the blood vessel, hematoma formation. Then callus formation, internal callus, which is fibrous tissue and cartilage. internal fibrocartilaginous callus formation. Hematoma formation, fibrocartilaginous callus formation, then bony callus formation. Callus two types. First is fibrocartilaginous, where there is fibrous tissue and cartilage. Then this fibrous tissue and cartilage is replaced by the bone cell, by osteoclast. Then there will be bone remodeling, means bone will try to reshape into its previous uh, size and shape. Okay. Factor affecting healing. Factor affecting healing. Local. Okay. Factor V for vascular injury. Femoral head, tetanus, talus, and scaphoid. Okay. AVN. If there is any vascular injury, then this is the major factor for bone healing, because first we have seen here hematoma formation. First hematoma have to be formed, then there will be callus formation of fibrocartilaginous callus, and the content will come from the blood vessel. So if there is blood supply, then it is sure bone will heal, because healing components or materials are present in the blood. But if there is no blood supply, then no chance, no hope. That's why first affecting factor is vascular injury. If vascular injury, bone will undergo avascular necrosis. It happens in femoral head fracture, talus, and scaphoid. Then infection, then drugs, some drugs like steroid, also degree of trauma, immobilization disorder, diam, osteoporosis. Then AM, A is age and smoking and malnutrition. Now, local complication of the fracture. There will be urgent, less urgent, and late. Late complication first. There will be delayed union, malunion, non-union, avascular necrosis, muscle contracture, joint instability, and osteoarthritis. And immediate vascular injury, nerve injury, compartment syndrome, hemarthrosis, infection, gas gangrene. Less urgent, fracture blister, plaster sores, pressure sores, nerve entrapment. This all happens because of the immobilization. Myositis ossificans, ligament injury, tendon lesion, joint stiffness. These all are related with the immobilization or cast. Montidier fracture and Gallagher fracture. Okay, this is exam question. Montidia and Gallagher. You can see the picture. This is Montidia and this is Gallagher. In Montidia, the radius dislocation at the head. Walaikum assalam. कहाँ पर गिर गई, कब गिर गई थी, आज कब या अभी अभी? थोड़ा मूव करे ऐसे, ऐसे बाकी सब कुछ हो रहा है, ठीक है, सिर्फ दर्द है, दर्द का टीका लगा दिया, ये कुछ नहीं है और कुछ नहीं है, सिर्फ इधर ये दर्द है। ठीक है, हम इंजेक्शन लगा देंगे, इसका टीका जो है रगड़ों को अपन जरासीन के लिए। जी, ये दे दीजिए, ये जरासीन वाला ही है ना? हाँ हाँ। Okay. Montigia, you can see. Just remember few points. Ulna, fracture of the proximal third of the ulna. This is proximal and this is distal. Ulna fracture will be in the proximal third. Okay, proximal third. And here ulna subluxation or dislocation of the distal radioulnar joint. Radius Okay. So in Montedia fracture, there will be dislocation at the radial head and ulna fracture in the proximal third. Mechanism no need, management or if, and limitation of motion in the elbow no need. Just uh, focus on these 2 points. What happens in radial? What happens in ulnar? Sorry. Okay, attention. In Montedia fracture, just focus on these 2 points, radius and ulnar. In radius, in Montedia, radius and ulnar. Radius will be dislocated at the head. Radius head will be dislocated. Okay, and ulnar proximal third fracture. Fracture of the proximal third, ulnar. This is Montedia. Finish. Both option treatment is ORIF. Okay, ORIF. Open reduction, internal projection. In Galeazzi, in radius fracture at the junction of the distal and middle third. In Galeazzi, mainly there will be radius fracture. Okay, and ulnar stabilization or dislocation. Yeah, fine. Yeah. Why you did this test? Uh, your report is normal. It is non-reactive. Okay. Hepatitis B also negative. Hepatitis C also negative. Hepatitis B and C. Yeah, negative. Okay. This is your report. Okay. You are taking any medicine for anything? Why you did this test? Why you did this test? For any disease or anything? Hmm. Hmm. Okay. Now it is non-reactive. He's safe now. So whatever treatment he took, it was effective. Okay. Now he is safe. Okay. Don't worry. Okay. Okay, brother. Here you can see. You can remember only this. Remember these 2 points. In Montegia, proximal one third of the ulnar fracture. This is radius and this is ulnar. Proximal one third of the ulnar fracture and dislocation of the radio-ulnar head. Radio-ulnar head will be dislocated here, and proximal one third of the ulnar fracture. And in Galeazzi, distal one third of the radius fracture. In Montegia, ulnar fracture. In Montegia, ulnar fracture, and Galeazzi, radius fracture. Radius, which radius? Distal one third of the radius fracture, and distal radio-ulnar joint. Radio-ulnar joint distal, both distal. In Galeazzi, both distal. Yes, one third of the radius
Radio
and distal
com
area and this disruption. In Galeazzi, both are distal. Fracture also distal radius, dislocation also distal radius. Colles fracture. Colles fracture. It is a transverse fracture of the radius, 1 inch proximal to the radiocarpal joint. This is radiocarpal joint. From the radiocarpal joint, within 1 inch of the radiocarpal joint. Sometimes instead of 1 inch, they can say 2.5 centimeters. Same. Okay. So transverse fracture of the radius Colles fracture, mainly fracture of the distal radius. Which distal? Within 1 centimeter of the radiocarpal joint. And dorsal displacement and angulation. There will be dorsal displacement and angulation. Like the picture you can see. Dorsal displacement and angulation. And dinner fork deformity. It will look like a dinner fork, this picture. Dorsal displacement and angulation. So it looks like a fork, dinner fork. Most common fracture of the distal radius. Okay. Smith fracture. This is opposite. Just we have seen uh, dorsal displacement and angulation, and it will be opposite. A reverse Colles fracture. It will be volar displacement and angulation. It will be volar displacement, means it will come forward. Forward. Colles fracture is backward, and volar displacement it is anterior or forward. Volar displacement and angulation. This is Smith fracture. Colles is like this, back. It will be like a fork, like a dinner fork, like this. And volar is forward. Volar is forward, anterior. This is Smith. Smith fracture is volar displacement and angulation. Barton fracture, exam question. Fracture dislocation of the radiocarpal joint. Fracture dislocation of the radiocarpal joint with intra-articular involvement. Volar Barton is the most common. Oriv displacement unstable. Okay. Volar Barton. This is kind of this. Volar Barton also looks like Colles fracture, but it is intra-articular. If it is intra-articular, then it will be Barton fracture. This is Bennett and Ronaldo. Ronaldo, you can remember one, two, and three. Three fragment. It is Ronaldo. But if it is two fragment here, then it is Bennett. This is phalanx. Pierce thumb or gamekeeper's thumb. When there will be hyperextension of the thumb. Okay. Rupture of the ulnar collateral ligament. Ulnar collateral ligament. Thumb when there is hyperextension caused by forced abduction. Then there will be rupture of the ulnar collateral ligament. Types of fracture: toddler fracture, oblique spiral fracture of the distal one-third of the tibia in infant. It is called toddler fracture. Green stick fracture, undisplaced cortical breech fracture. Okay, these are plastic deformity, unifocal compact, not important. Ankle fracture already we have seen. Ligament of the ankle, deltoid ligament. Third strongest ligament in the body, regis valgus. Okay, normal anatomy, no need. We have already seen. Syndesmotic disruption is instability. Syndesmotic. Remember, we have said ABC. High ankle sprain, syndesmotic injury, long ankle sprain, lateral ligamentous compression. Okay, these are known CTMRI. Yes. Dennis Weber classification already we have seen ABC. Mesuveni fracture. This one is syndesmotic disruption with proximal fibular fracture. If proximal fibular fracture with syndesmotic joint also fracture. Mesonevu fracture, mesonevu injury. This is proximal fibula with syndesmotic disruption. Okay, this is called mesonevu injury. treatment is already we have seen. If it is Weber A, full cast ankle boot. Weber B usually depends on the stability. If it is stable, then if unilateral, unimanual, okay, it will be stable if only unilateral. And if it is bilateral, then it is unstable. Weber type B. And type C require internal fixation. You can read here Weber type A, type B, and type C. Already we have seen, and treatment also we have seen. Then trigger finger, locked in flexion, released by manipulation, tendons thickening, nodule formation. Management according to the severity, surgical release of A1 pulley mainly. So this is A1 pulley, this one, and this is the tendon, flexor tendon, and there is formation of a nodule. This nodule entraps proximal to the pulley. So treatment will be only release of the pulley and patient will be symptomless. Then ganglion, uh, this originates from the joint capsule. Firm, smooth, cystic lesion, painless, develops over the joint or the tendon sheath, and recurrence rate is 25%. Even if we do the surgery, 25% case, it will again come back. Triggered thumb, this is that fully already we have seen. Liquid tenosynovitis, no, yeah, this is all. Yeah. Yeah, you can go to
Pretest?
fastest. Yeah.